Good morning, everyone. Good afternoon. So a warm welcome to this oral abstract session, The Race for Improved Multidrug Resistance Care. This session will focus on the implementation of new recommended MDR-TB regimen and ways to improve MDR-TB cares on the programmatic condition in high burden and resource-limited settings. My name is Marilyn Bonnet. I'm working as a medical epidemiologist at the French National Research Institute for Sustainable Development in Montpellier, France. And I'm coordinating clinical research on tuberculosis. Margaret Dalcolmo is my co-chair. She's a respiratory physician with clinical research practice. She's in charge of MDR-TB surveillance in Brazil, and presently she's conducting the SIMPLICE TB phase 3 trial of reducing treatment time for MDR-TB and susceptible TB case sponsored by Global Alliance. So MDR-TB care benefits a lot from recent advances in treatment with the introduction of the new drugs, the move towards short treatment duration and injectable-free regimens. However, it's important to pay attention to implementation aspects of this new recommendation in high burden and resource-limited settings. So this session includes 8 presentations that will address different aspects of the implementation of MDR-TB cares, and will be followed by 10 minutes for question and answers. So we invite you to write your question in the chat box for questions through the presentations and to mention to whom, which speaker you address the questions. So I will over to Margaret to introduce the speakers.
Well, good morning. It's my pleasure to start this presentation. And so we are going to have each presentation one after one. And at the end, as Marilyn mentioned, we're going to have to select questions and to raise for the presenters. The first presentation will be raised by Tiziana Mazzini, and she's going to present on the best practices on bedaquiline and delamanid use for resistant TB management, implementation of extension and combination use in 43 high burden countries. So Tiziana, you can start, please. Tiziana.
Hello everyone, I'm Tiziana Mazzini, and today I'm going to present the results of the 2020 Step Up for TB project, previously called Out of Step, which MSF carried out in collaboration with the Stop TB partnership. I will focus this specific presentation on the project findings related to bedaquiline and delamanid and on how national policies in the countries that we surveyed reflect best practices in bedaquiline and delamanid use for the management of DRTB. Okay, I have no conflict of interest to disclose. So the main objective of the Step Up for TB 2020 report is to assess the extent to which national policies align with international best practices for TB diagnosis, prevention, treatment, as well as drug regulation. To do so, we interviewed national TB program managers or assigned focal point in 37 high TB burden countries through a semi-structured questionnaire, and we also collected additional data through desk review of available national policy documents. The countries surveyed represent 77% of the global estimated TB incident cases. The report, which is the 4th of this series, will be launched soon, and should you have any question on the project and on the report in the meantime, please feel free to reach out to Sharon and Lynch at the email address that you see in this slide. Okay, so this slide summarizes the latest WHO recommendation on the use of bedaquiline, delamanid, and their combined use as well. So the use of both drugs as well as the combined use beyond 6 months is possibly, their use beyond 6 months as well as their combined use based on WHO recommendations is only possible following the practice of label use, despite more and more available evidence emerging on their safety safety, and also their role in improving treatment outcomes, including the results from the MTB observational study, which I'm sure most of you are familiar with, which is carried out in a cohort of patients with high rates of fluoroquinolone resistance. Okay, on top of a policy gap, data from the DRTB stat also highlight that there is clearly an access gap. In fact, even though up to 80% of patients started on treatment would need bedaquiline for an all-oral regimen, access to bedaquiline as well as to delamanid has remained really low compared to the global estimated need, as you can see from this graph, which I took from the DRTB Stat website. Going now to the findings of the STEP-UP for TB 2020 survey, our findings show that some countries still do not include bedaquiline or delamanid, or both of them, even in their national policies for routine treatment, which is really alarming. And among the countries that do include them, only a small percentage indicates that their extended use beyond 6 months it's possible without the need for a special approval. Also, very often the information in the policy for extended use of bedaquiline, delamanid, and their combination is often not clear in the national guidelines. Here, I added a screenshot of the Liberia 2019 National Tuberculosis Management Guidelines, which is what we really hope to see in all national TB guidelines in the near future. As for the combined use, the survey findings show that while most policies indicate the combined use for bedaquiline and delamanid for routine treatment, only a small percentage of countries allow the combination to be used beyond 6 months without a special approval. While we did not look at the combined or extended use of bedaquiline and delamanid for pediatric populations, we assessed that most national policies are in line with current WHO recommendations in terms of the youngest allowable patient age for bedaquiline and delamanid. However, while this is very promising, still 30% of the countries that we surveyed do not indicate injectable-free all-oral regimens for children with uncomplicated forms of drug-resistant TB. In general, however, the survey findings show that the majority of the countries are moving fast toward implementation of all-oral regimens. In fact, majority of the countries started or completed the implementation of a long all-oral regimen for the routine treatment of adults with DRTB by December 2019. And in terms of the modified shorter all-oral regimen, in terms of the modified shorter all-oral regimen, 61% of the countries included in their national policies such a regimen, either for routine use or for operational research, and almost half of them have implemented or started implementing it under operational research, pilot conditions, or even routine use by December 2019, which is, by the way, the cutoff of our analysis. So to wrap up, there are still clearly major access as well as policy gaps in terms of bedaquiline and delamanid in general worldwide. However, on top of that, our survey findings show that most national policies do not indicate extensions of the medicines, also in combination, unless special approval is granted. This is particularly alarming, especially given that most countries are moving fast toward all-oral regimens, where especially bedaquiline plays an absolutely key role. So countries should really make sure that their policies on bedaquiline and delamanid are clear and bold, and that both drugs may be used throughout the whole duration of the treatment if needed, with no extra steps such as special approvals that may delay the initiation of treatment. Operational research and systematic collection on expanded use of bedaquiline and or delamanid can make countries more familiar with these practices and can also speed up national policies updates. And there are many opportunities that countries can and should exploit to engage in these activities. Thanks a lot.
Good day. My name is Wasila Jasat, and I am from Johannesburg, South Africa. And I am here to speak to you a little bit about my PhD studies. I've always been interested in understanding why evidence-based policy fails in implementation. In trying to answer this question, I will share my exploration of implementation of the drug-resistant TB policy in South Africa. South Africa is one of the highest burden countries for drug-resistant TB in the world. Since the first case of XDR TB was described in Tugela Ferry in 2005, the country has launched a policy response that included new diagnostic and service delivery models, as well as more recently, the introduction of new drugs and drug regimens. There's also been some effort to address funding gaps with creation of ring-fenced funding for drug-resistant TB in 2018. I chose to focus my research on exploring the implementation of the 2011 policy for decentralization and deinstitutionalization of drug-resistant TB care. This policy shifted treatment from 15 provincial centers of excellence that existed in 2011 to decentralized and satellite units within each district, including the involvement of primary healthcare clinics and mobile teams delivering community-based care. A policy such as this would require significant changes in the way services are organized and delivered, the way human resources are distributed and the skills that they would need, in diagnostic and drug delivery systems, referral pathways, information systems, program financing, and overall coordination and communication. So the purpose of my PhD was to explore and describe the implementation of this policy in two provinces of South Africa, KwaZulu-Natal and Western Cape. The provinces were chosen because they both have high burden of disease and they've had a very different approach to implementing the policy. Western Cape rapidly decentralizing to every primary healthcare facility and KZN adopting a slow, cautious approach. The conceptual framework that guides the study is rooted in the policy analysis triangle, which examines how content, actors, and processes of policy interact in context-specific ways to inform implementation. I employed a comparative multiple case study design, the cases being the implementation of this policy in two provinces, and the embedded sub-units were 25 health facilities, representing a number of different models of service delivery that had evolved. The value of a case study design is it provides rich, deep, and nuanced data, allowing us to understand how and why the program was implemented as it was. I used a multi-method approach to data collection, relying particularly on qualitative sources of data, including 90 interviews with policymakers, implementers, and experts in the field. The value of this approach was to examine multiple perspectives, which enables understanding of the complex causality in implementing public health programs. I would like to share just a few thoughts and reflections on findings of this research presented as tensions and contestations in policy implementation. In the policy content domain, I identified contestations around policy meaning and intent and the resultant models of care that emerged. Stakeholders shared different interpretations of the goals of decentralization and deinstitutionalization, and they had very strong and divergent views about the appropriateness of decentralizing drug-resistant TB. This resulted in contestation around policy priorities and differences in the model of service delivery implemented. Some districts continue to have an institutionalized model of care, providing services in hospital. Others provided care at primary healthcare level, while still others provided care in the community and through mobile teams. Some districts had a very centralized approach to decentralization, basically replicating the provincial center of excellence at a district level, so having just one facility within the district to deliver drug-resistant TB care, thus leaving clients still facing significant barriers to access, traveling vast distances and long hours to seek care. In the domain of policy context, there was some contestation around how new policy should be resourced. Unlike the HIV program that has had a ring-fenced conditional grant for almost 20 years, funding for TB was ring-fenced only 2 years ago. When this policy was launched, it was not accompanied by dedicated funding except for the construction of a few drug-resistant TB units. Many people at the coalface describe this as an unfunded mandate. Others believe differently, that it was up to managers to shift resources from the provincial centers of excellence to lower levels of care. Some informants, however, believe that the resources should not shift down, but should leverage the staff, drug and lab budgets that already exist at primary healthcare. However, adding additional services in an already strained and overwhelmed primary healthcare clinic has resulted in rationing of care and compromise in quality. In the domain of policy actors, I found a much more nuanced understanding of power and influence for implementation. In many districts, power rests with drug-resistant TB clinicians by virtue of their expertise and professional standing, rather than the district TB program manager who is responsible for supporting implementation. Actors influence implementation positively and negatively through their perceptions and organizational politics and the presence of champions and resistors of change. Champions do influence implementation, but often in conflicting ways. Policy champions were motivated to implement national policy and served as catalysts to further decentralize drug-resistant TB in their districts. Program or quality champions seemed to resist decentralization, but were actually passionate about drug-resistant TB and had concerns about decentralization that it would negatively affect quality of care. Even resistance to policy is complex. I noted drug-resistant TB clinicians who were resistant to rapid decentralization because of their concerns about poor quality of care at lower levels. I also noted hospital managers who resisted and even sabotaged decentralization because when patients would shift to lower levels, their facility headcounts would drop, creating concerns that budget and staffing would be cut. In the domain of policy process, the major tension was who was responsible for coordination of policy implementation. New policy naturally cascades from the policymakers in the TB Directorate at the National Department of Health to the TB program managers at province and district and to the drug-resistant TB hospitals. The risk of bypassing provincial and district management structures is that it entrenches verticalization and results in lack of ownership by the district, which leads to challenges in coordinating stakeholders and mobilizing resources for implementation. I identified the important role of facilitation of policy implementation in one setting, which employed multidrug-resistant TB sub-district coordinators who were critical in driving implementation, addressing challenges, and improving quality. As South Africa moves towards bold and progressive new treatment policy, we need to learn from lessons over the past 10 years. This study has revealed insights around how we communicate the objectives of new policy, around actor and network roles, and strategic leadership and management required to support implementation. A better understanding of policy dynamics will contribute lessons for strengthening future implementation of drug-resistant TB policy. Thank you for your time.
Dear special guests and participants of the 51st Union Conference on Lung Health, good morning. The presentation that I will give today is entitled Programmatic Management of MDR XDR TB patients using the short treatment regimen from 2015 to 2019 in Cameroon. This is the result of collaborative management during 5 years, in addition to data collection by the Cameroon National TB Program team, hereby represented by the unit heads, Albert Kouyaté, Edwige Bellinga, Vincent Bassa, and others. I'm Christelle Jouego, a medical doctor working as referral clinician for drug-resistant tuberculosis for the National TB Program of Cameroon. This presentation falls under the section 1, entitled The Race for Improved MDR Care at the 51st Union World Conference held on virtually this year. For the background and challenges to implementations, in Cameroon, we have been using the short treatment regimen, also known as Bangladesh regimen, since 2015, under programmatic management for all the rifampicin-resistant and drug-resistant TB cases, which are well followed by the staff and the treatment center. We have up to date 11 treatment centers for drug-resistant and tuberculosis in all the regions. We have 10 regions and we have 11 treatment centers, in addition to 1 center in the prison. The country is having 2 national reference laboratories for culture and drug susceptibility testing for all the patients, following a well-known and organized transport system and linkage from centers to each laboratory. And then we have devoted and trained staff which follow the national operating procedures and the guideline for the management of drug-resistant tuberculosis. As of method, data from patients receiving the short treatment regimen from 2015 to 2019 in all the treatment centers were recorded, initially on the patient treatment card and after on the quarterly basis by a health staff trained on data collection by the NTP. The data were collected, those data were on patient card were entered inside the EpiData database software on a quarterly basis. We hereby describe their basic information, including occurrence of side effects and availability of their second-line LPA results. During the past 5 years period, 706 drug-resistant TB patients were notified by all the 11 treatment centers of the country of being started on the short treatment regimen. In this population, we are able to see that 63% were male, as usual with tuberculosis. 71% of these patients were registered as high-risk group. I intend by high-risk group relapse cases, failures, and failure from previous tuberculosis treatment. And 27% in this population were recorded as new cases for tuberculosis. Out of these patients, we had 99% who had an HIV test result available, and from which 31% had an HIV positive test. The whole population, we recorded 3% and 4% respectively of second-line resistant drug for fluoroquinolone and 4% for second-line anti-tuberculosis treatment. Regarding the treatment outcome, 82% of patients had a favorable outcome, notified among those who were put on treatment, and then unfavorable outcome, I intend by death, failure, loss to follow-up, represented 18%. Among those 18% of unfavorable outcome, 12% were death cases, 4% loss to follow-up, and 1% represented the failure to the treatment. According to the available literature, we know that we read that third degree and more are considered as severe adverse drug events. We hereby present the third degree adverse event that occurred among the study population. We had a proportion of 4% who actually developed third degree adverse events. And among this population, the main systems that were affected were respectively the auditory system in 72% and the hepatic system at 17%. For conclusion, we therefore draw the following points. Programmatic management for drug-resistant tuberculosis and rifampicin-resistant tuberculosis using the short treatment regimen has shown good therapeutic results for the past 5 years in Cameroon under programmatic management. The severe adverse events from third degree upward represented 4%, among which ototoxicity followed by hepatic problem in 17% were the mostly represented side effect by patients. And while going towards a fully oral regimen recently adopted by the WHO, we advocate after this data, we advocate for the necessity of a closer patient monitoring by all the national TB programs. Thank you.
Hi everyone, my name is Alexander Lim, or you could call me Alex. I am currently working in the Department of Health, Philippines. I would like to thank everyone for making time to watch this presentation and for the opportunity to share our research, our year-long research in the Philippines. Our presentation is entitled The Outcomes of a Representative Sample of Patients Lost to Follow-Up During Drug-Resistant Tuberculosis Treatment in the Philippines. Let's get started by defining what loss to follow-up or LTFU is. Loss to follow-up or LTFU is defined as missing more than 2 months of treatment. It is quite common in the Philippines Programmatic Management of Drug-Resistant TB, or the PMDT program. And as reported by the 2019 Joint Program Review of the Philippines NTP, it makes up LTFU patients makes up around 31 to 33% of the total population of DRTB patients from 2013 to 2016. LTFU patients are usually excluded when reporting program outcomes, potentially biasing estimates of program success. With these in mind, our objectives are as follows. So 1, to determine the vital status of a cohort of MDR-TB patients whose treatment outcome was recorded as lost to follow-up, and to update mortality estimates after including LTFU patients. From a parent cohort of 683 patients comprised of all pre-XDR, XDR patients treated through the PMDT program of the Philippines, and a random sample of MDR-TB patients also treated to the PMDT program in the Philippines, both of these groups with culture isolates available at the National TB Reference Laboratory at the Research Institute of Tropical Medicine in the Philippines. A sample of 225 patients were eligible for tracing, with 203 or 90% having the loss to follow-up outcome and 22 or 10% having the treatment failed outcome. Here's the process that we did for patient tracing. Eligible patients were traced by searching the PMDT electronic database to identify additional episodes of care. Tracing was stopped with patients who had additional treatment. Those with unknown outcomes were grouped into 2. Patients with contact details were called up 3 times on separate days using the listed personal and emergency contact numbers. Patients not reached through phone call were visited at the most recent address with assistance from local public health staff. Patients successfully traced were interviewed regarding their current health status and TB treatment history. If immediate community members were contacted, only vital status information was collected. And if the patient was alive and unavailable as of the moment, a new contact information was obtained and they were called up again. Of the 225 patients with an original treatment outcome of loss to follow-up or treatment failed, 40 had additional treatment episodes, 13 of whom died, 24 successfully treated, 3 ongoing treatment. 185 patients were considered for phone call tracing, and 170 of whom had a valid contact number. Vital status was obtained through phone call for 37 patients, while the remaining 148 were considered for home visits. Ultimately, 123 patients were traced successfully through home visits. Overall, 200 out of 225 patients were successfully traced. This is 89% of the total population, and 59 out of the 200 or 29.5% of these patients died. After tracing, the known mortality rate increased from 11.7%, which comprises of 80 of the patients, to a percentage of 20.4%, which comprises of 139 out of 683, having a difference of 8.7% at 95% confidence interval 6 to 11. This would be the last slide. We can conclude, therefore, that tracing drug-resistant TB patients who are lost to follow-up is feasible and identified additional mortality. Tracing a random subset of patients lost to follow-up should be considered in routine program to better reflect true program outcomes. And thank you very much. Maraming salamat po for listening to our presentation. I hope that that everyone here stays safe. Thank you.
I have no conflict of interest. Dear all, it's my pleasure to present our project entitled Undiagnosed Drug Resistance in MTB is Associated with High Mortality in Countries with High TB Burden, My name is Martina Reichmuth and I work for IDEA at the University of Bern in Switzerland. Please note that the data presented here has been published as a preprint on medRxiv. In the next few minutes, I would like to talk about the importance of identifying and treating drug-resistant TB effectively and about associated mortality. Drug-resistant TB threatens the control of TB. The World Health Organization underlined the need to improve the quality of drug susceptibility testing and treatment of drug-resistant TB, especially in countries with high TB burden. Whole genome sequencing has the potential to predict resistance to most anti-TB drugs and is increasingly replacing other testing methods. However, the potential of whole genome sequencing in routine clinical care in low and middle income countries has not yet been explored. In this project, we aimed to compare DST performed in 7 high TB burden countries. I will also refer to it as locally, with the results obtained from centralized whole genome sequencing. This was performed at 2 well-established facilities. In the next step, we analyzed mortality during TB treatment, comparing concordant and discordant drug resistance results. This study is part of the International Epidemiology Database to Evaluate AIDS and builds on our article published last year, where we compared the results of local DST with standard phenotypic DST. This was done for 6 anti-TB drugs. Now at the Swiss TB Reference Laboratory. Now we want to expand this analysis to all known anti-TB drugs using whole genome sequencing. All patients were older than 15 years and had pulmonary TB. On the world map, we see the incidence of TB. And the 7 countries participating in this study are marked with a red cross. So namely, Peru, Thailand, Ivory Coast, Nigeria, Kenya, DRC, and South Africa. All countries performed DST according to the available testing method. For the same isolate, we performed whole genome sequencing and screened the drug resistance conferring mutations. In our study population of 582 TB patients, we had 58% pan-susceptible cases. The median age was 33 years and 39% were female. 42 were HIV positive. This was expected due to our sampling strategy. The Venn diagram shows in red resistance profile obtained in the 7 countries, so locally, and in yellow, drug resistance obtained by whole genome sequencing. Based on whole genome sequencing, approximately half of the isolates were pan-susceptible and 1/3 were multidrug resistant. We then compared drug-resistant categories from local DST and whole genome sequencing. The overlapping area in the Venn diagram shows that 80% of pan-susceptible, 8% of monoresistant, 66% of multidrug resistant, and 33% of XDR TB cases were concordant, meaning that the same results were obtained by local DST and whole genome sequencing. In contrast, we see some areas that do not overlap, meaning there were discrepancies between the local and DST and whole genome sequencing. A discordant diagnosis especially undiagnosed drug-resistant, can influence the treatment decisions. Please have a look at the table. In the second last row, you can see a person with MDR-TB according to whole genome sequencing, but who was locally diagnosed with INH monoresistance. This is what we called underdiagnosis and could potentially lead to undertreatment. In contrast, the person would be overdiagnosed if also diagnosed with fluoroquinone resistance, instead of MDR only. Among the 530 isolates for which we had corresponding data, 121 had a discordant diagnosis. 30 patients received a diagnosis which potentially led to undertreatment, and the mortality was 27%, as you can see in the bar plot. Whereas in patients with concordant diagnosis, the mortality was 11%. In about 1 of 5 patients, the diagnosis was discordant between local DST and whole genome sequencing. Routine DST at the 7 high TB burden countries focused on identifying RIF and INH resistance. And therefore, other drug resistance were often not diagnosed. With whole genome sequencing, several drug resistance can be detected simultaneously. This can help to improve individualized TB treatment, which is beneficial for patients, as they are more likely to receive adequate treatment, and the risk of spreading drug resistance is reduced. Many thanks to all collaborators and for your attention.
It's a good afternoon, ladies and gentlemen. My name is Kenneth Mutesa from Uganda. I work on the USAID Defeat TB project. The USAID Defeat TB project is a 5-year technical assistance mechanism for the National TB and Leprosy Program to increase TB case detection and treatment success rates using a health system strengthening approach. And it is implemented by a university research company and its partners. Next slide. Now, I have no conflict of interest to report regarding the work I'm about to share. And I'm going to give a talk on the predominant yield of drug-sensitive tuberculosis among contacts of multidrug-resistant TB patients in Uganda, a call for next-generation sequencing. This work has been done by a team, and I'm representing them to present the highlights and the lessons we see. Next slide. So in terms of the implications for MDR-TB work, these lessons call for further study of the TB transmission dynamics among contacts of MDR-TB patients, and for innovations for early diagnosis of MDR-TB, given that we are a bit behind on MDR-TB case detection. Next. So as a bit of introduction, early detection and treatment of multidrug-resistant tuberculosis is critical to reducing transmission and mortality, but also for a catch-up on the treatment coverage for MDR-TB patients. As we are aware, by 2019, globally, only 30% of the estimated MDR-TB patients access treatment. And so systematic screening for contacts of index TB patients and high-risk groups is a key end TB strategy for early TB diagnosis. The Ministry of Health National TB and Leprosy Program has developed guidelines for contact investigations, which recommend screening for all contacts of MDR-TB patients at treatment initiation, and thereafter at least 6 months for all contacts. Now, the USAID Defeat TB project provides the technical assistance for programmatic management of drug-resistant TB, and this happens at 17 hospitals, which is a combination of regional referral hospitals and general hospitals. And these services include contact investigation. And so the team analyzed the MDR-TB contact investigation cascade to determine the yield of TB, but also the gaps for improvement of the cascade, given the low case detection for MDR-TB. So in terms of the methods, standard procedures for systematic contact screening were followed to line list contacts and trace them and conduct a symptom screen for patients that were notified from January to December 2019. The samples from presumptive TB patients were tested using GeneXpert, and contact investigation registers were used to capture and track contacts who completed each step of the evaluation cascade. So the team performed a descriptive analysis of the numbers and proportions completing each step of the cascade and the yield of TB from the activity. Next slide. So into the results, we see that during that period of January to December 2019, a total of 541 MDR-TB patients were notified and started on treatment. And out of these, 4,500 contacts were identified and line listed, and 94% of those were screened for TB. Now that screening and testing with expert yielded 3.2% of the contacts with TB. That's a total of 134 contacts with TB, of which the majority, that is 81%, had drug-sensitive TB, with only 19% having rifampicin-resistant tuberculosis. And this was also consistent with the number needed to screen. For detection of one RR case, we needed 169 contact screen, compared to only a quarter, which is 39 contact screen to be able to detect one person with drug-sensitive TB. Next slide. So in conclusion, contact investigation is a feasible strategy for active TB case finding in the community. However, the predominant yield of drug-sensitive TB among contacts probably points to greater community than household transmission and merits further inquiry. So we recommend scale up of drug-resistant TB contact investigation as an active case finding strategy. And additional innovations for early DRTB case detection. As we have noted, these contacts predominantly are having DSTB, and yet the DRTB case detection is still low. And we also recommend further inquiry, including next generation sequencing for DRTB contacts that are diagnosed with TB in order to understand the transmission dynamics of TB among contacts of multi-drug-resistant TB patients. Next. So in conclusion, I've already concluded. I acknowledge the following organizations: the Ministry of Health National TB and Leprosy Program for the guidance and support, the United States Agency for International Development for the funding for this activity, the USA Defeat TB, University Research Company staff, the regional referral and general hospital multidisciplinary care teams for MDR-TB, and the TB patients and their families. I thank you very much for listening.
Hello, Dr. John Paul Otuba is my name. I work for USAID Defeat TB project in Uganda as the MDR-TB technical advisor. Defeat TB is USAID's TB flagship project in Uganda that supports the National TB and Leprosy Control Program to find all forms of TB and treat them successfully. I have no conflict of interest to declare. This is the title of my paper, Achieving High Treatment Success Rate for Drug-Resistant TB Following Introduction of a Novel Shorter Treatment Regimen. This picture depicts a facility team at one of the MDR-TB treatment centers in Uganda that was being supported by Defeat TB to review the record of their patients that are enrolled in a case-based system for MDR-TB management or surveillance in Uganda. A background, Despite significant milestones in the global TB control, treatment success rate among multidrug-resistant TB patients has remained low. The World Health Organization updated its treatment guidelines for drug-resistant TB in 2016 to include recommendations on the use of novel injection-based shorter treatment regimens, and thereafter in 2019 to phase out injection-based regimens in favor of all oral treatment. Uganda as a country adopted the shorter treatment regimen. This was a 9 to 11 month regimen in April 2018 and enrolled patients based on the WHO eligibility criteria. The patients that qualified to be started on the shorter regimen were patients that had no documented or suspected resistance to any of the agents in the seven drug regimen. 2, the patients that had no extended resistance to any of the molecules. 3, the patients shouldn't have been pregnant. The patients shouldn't have been having extrapulmonary or severe TB disease. So that is the criteria that was followed. The research was to determine the estimates of successful, that was cure, completed or both, or poor outcomes. And we're looking at death, failure, and loss to follow-up among the patients that were enrolled into the shorter regimen in 2018. What were the methods? Defeat TB conducted a retrospective data review of all the medical record of 388 patients started on MDR-TB treatment at all the 17 drug-resistant treatment initiation centers in Uganda. This ran between April and December 2018. We extracted data from a DHIS2-based database that is managed by Defeat TB Project. This is a case-based DRTB surveillance system that Uganda uses for tracking the management of patients with drug-resistant TB. We assessed the treatment outcomes for only the bacteriologically confirmed rifampicin or RRTB patients and those that were confirmed to have multidrug-resistant TB. We used outcome definitions, treatment outcome definitions and classifications that were included in the 2016 updated WHO treatment guidelines. That came along with the guidance on the management of drug-resistant TB using shorter treatment regimens. Our results of the 388 medical record reviewed, 45% of the patients were found to be on the shorter regimen and were included in the evaluation. The patients that did not meet the criteria for being enrolled on a shorter regimen were enrolled on previously referred to 20 to 24 months conventional regimen, and they were excluded from this study because by the end of the evaluation, they had not completed their treatment. 30% were female with a median age of 36 years, and the final treatment outcomes were 71% of the patients had a cure outcome, 8% had completed their treatment, 9.7% of the patients had died, 4.5% were lost to follow-up, and 6.8% experienced a treatment failure outcome. What did we conclude from the study? 1, the treatment success rate among the patients on the shorter treatment regimen was 79%, which compares favorably with the national drug-resistant TB treatment success rate target for Uganda, which is at 80%. The case fatality for these particular patients in the short-term treatment regimen was high at above 9%. And we recommend that further evaluation and research should be conducted to try and understand and mitigate the drivers of mortality among the MDR TB treatment cohorts in Uganda. We acknowledge the following: USAID for the funding that was provided to the project, University Research Company, the National TB and Leprosy Control Program, Ministry of Health, Uganda, and all the MDR TB treatment initiation facilities in country. Thank you very much. Hello, Dr. John Paul Otuba is my name. I work for USAID Defeat TB project in Uganda as the multidrug-resistant TB technical advisor. Defeat TB is USAID's TB flag project in Uganda that supports the National TB and Leprosy Control Program to support case finding for all forms of TB and TB treatment success. I have no conflict of interest to disclose. The title of my paper is Introducing Facility-Based Mortality Reviews into the Programmatic Management of Drug-Resistant TB, Lessons from Uganda. I start off the paper with a picture from one of the MDR TB treatment initiation facilities in Uganda. And this is the facility team here that is reviewing one of the patients that had actually been, they had lost with support from the advisor from Defeat TB project. Background: reducing tuberculosis deaths is one of the World Health Organization's NTB strategy targets. Death among MDR TB patients in Uganda remains high at approximately 19% of the cohorts that are started on treatment. Defeat TB project supported all the 17 treatment initiation facilities in Uganda to pilot a facility-based mortality reviews. The methods used: the project developed a mortality case review form to capture demographic and clinical data for patients who had died between 2016 and 2019. We had teams set up at the 17 treatment initiation facilities, conducting a combined 79 mortality reviews between June 2018 to December 2019 to review cause of death, identify patient and system factors for improvement. What were the results? Of the 79 deaths, 39% were female with a median age of 35 years. 35% were confirmed multidrug-resistant TB patients. 63.3% were those diagnosed with rifampicin resistance, and only 1.3% of the patients had extended resistance to the injectable agent. Poor treatment adherence, which was defined as patients who had missed up to 30 doses or more of their treatment during a course of the month, were up to 32%. Approximately 56% of the patients that died died within the first 2 months of treatment enrollment. 64.6% of the patients had HIV-related comorbidities, with 86.3% of those that were co-infected with HIV on ART by the time they died. Approximately 14% of the patients had non-HIV Hello, Dr. John Paul Otuba is my name. I work for USAID Defeat TB project in Uganda as the multidrug-resistant TB technical advisor. Defeat TB is USAID's TB flag project in Uganda that supports the National TB and Leprosy Control Program to support case finding for all forms of TB and TB treatment success. I have no conflict of interest to disclose. The title of my paper is Introducing Facility-Based Mortality Reviews into the Programmatic Management of Drug-Resistant TB, Lessons from Uganda. I start off the paper with a picture from one of the MDR TB treatment initiation facilities in Uganda. And this is the facility team here that is reviewing one of the patients that had actually been, they had lost with support from the advisor from Defeat TB project. Background, reducing tuberculosis deaths is one of the World Health Organization's NTB strategy targets. Death among MDR TB patients in Uganda remains high at approximately 19% of the cohorts that are started on treatment. Defeat TB project supported all the 17 treatment initiation facilities in Uganda to pilot a facility-based mortality reviews. The methods used, the project developed a mortality case review form to capture demographic and clinical data for patients who had died between 2016 and 2019. We had teams set up at the 17 treatment initiation facilities, conducting a combined 79 mortality reviews between June 2018 to December 2019 to review cause of death, identify patient and system factors for improvement. What were the results? Of the 79 deaths, 39% were female with a median age of 35 years, 35% were confirmed multidrug-resistant TB patients, 63.3% were those diagnosed with rifampicin resistance, and only 1.3% of the patients had extended resistance to the injectable agents. Poor treatment adherence, which was defined as patients who had missed up to 30 doses or more of their treatment during a course of the month, were up to 32%. Approximately 56% of the patients that died died within the first 2 months of treatment enrollment. 64.6% of the patients had HIV-related comorbidities, with 86.3% of those that were co-infected with HIV on ART by the time they died. Approximately 14% of the patients had non-HIV-related comorbidities, particularly acute malnutrition, diabetes, deep venous thrombosis, cancer, kidney, and liver diseases. Possible system factors contributing to death included delays in diagnosis, and this was found in up to 58% of the patients that were evaluated. And the delays in diagnosis were defined as patients that had symptoms that had been documented that were longer than 1 month prior to them seeking health care from the facilities. There were also delays in enrollment in up to 48% of the patients. And these are patients that did not start treatment until after 7 days from their diagnosis. Drug toxicity was reported in 15% of the patients, of which 58% were serious adverse drug events. And these were events that either caused an admission or the patient was already admitted at the facility and had a prolonged stay or duration of admission. Those that experienced disabilities, particularly visual and hearing impairment, and those that had life-threatening conditions. What did we conclude from this study? One, more than 2/3% of our patients had comorbidities and died within 2 months of enrollment. The delays in diagnosis, linkage, poor adherence, and drug adverse events significantly contributed to death. We therefore recommend institutionalization of mortality reviews into the management of drug-resistant TB to continually identify and address drivers of mortality. Defeat TB worked closely with the National TB and Leprosy Control Program, learning from the findings of this study, and a number of interventions were put in place to address some of the drivers of mortality that were observed from this study. One, systems were put in place to link newly diagnosed patients to treatment in under 7 days from the date of diagnosis. Two, support was provided to the facilities to improve MDR TB HIV co-management, with all the MDR TB co-infected patients being managed at the MDR TB care point. Treatment adherence was strengthened through provision of enablers for transport from the patient's home to go to the follow-up facility for their daily directly observed therapy. And also the country provides these patients with nutritional support. The management of adverse events was also supported through strengthening the screening and management of adverse events through active drug safety monitoring and management. And last but not least, the project has been working closely with an expert panel of MDR TB clinicians to provide in real-time support on case decision for case management of MDR TB patients through a virtual video conferencing facility, the ECHO platform. We acknowledge the following: United States Agency for International Development, that is USAID, for providing the funding that supported the study and the interventions that were put in place thereafter. University Research Company, that is URC, that implements the Defeat TB project. The National TB Leprosy Program, Ministry of Health, and last but not least, the MDR TB treatment centers. Thank you very much.
Yes, so thank you to all the speakers for the very interesting presentation. So I'm Marilyn Bonnet, so I'm back to you with the question and answer. So we got several questions. I will start with the first questions to Martina Reichmuth regarding the whole genome sequencing. So the question is that since whole genome sequencing requires the native specimen to be cultured before performing sequencing, how would whole genome sequencing help in designing treatment regimen, knowing that we need to wait for several weeks before to get a positive culture? So wouldn't target sequencing using native specimen not better for a point of view of designing a regimen? So you can answer, please.
Thanks for this question. So target sequencing can be advantageous, but however, to overcome this time-consuming culturing, it would be advantageous to do sequencing directly from sputum samples. And there are currently interesting studies going on in several groups, and the literature is growing. So I think sequencing directly from sputum would be better and faster.
Okay, thank you very much. So the next questions is for Tiziana Massini. So what would be your recommendation on expanding use of combination and extension of bedaquiline-delamandine in high burden countries for patients who would potentially benefit for it? So this is more.
Thanks. So, well, there is enough evidence to support safe off-label use of both drugs beyond 6 months, as well as their combined use. And MSF has a lot of experience in the field and in their projects with these practices, especially for people with extensively drug-resistant TB and side effects to other drugs. And also, as I mentioned in my presentation, the evidence that came up from the anti-TB observational study, which shows that the use of bedaquiline and delamide beyond 6 months, as well as their combined use, is safe and effective. So MSF encourages all countries to create systems that allow proper monitoring of these patients, so as to be able to implement these practices. So in terms of a recommendation, I would say that the first thing that needs to happen is for countries to update their policies to allow these practices to happen. Like bedaquiline and delamide should be treated as all the other drugs, and clinicians should be free to recommend these drugs as well as they do with all other medicines. In my presentation, I showed the Liberia national TB guidelines as an example, and this is really what we aim to see in all national policies in the near future. Thank you.
Thank you very much. So the next question is for Christelle Joego from Cameroon. Is it correct that 73% of patients experience severe hearing loss? And this is a bit higher than what has been reported on previous experience using the Bangladesh regimen. And we would like to get your comment on it. And I would add also questions. Planning to move to the non-injectable shot regimen soon?
Thank you, Marilyn, for your questions and for the chat. Unfortunately, for the first question, we have been experiencing higher severe auditory side effects among patients. And the main reason that can be given here is that I think it was mostly due to the decision to stop the injectable before we had to update the guideline, and also to switch to other treatment or new drugs like linezolid or any other one. So actually our data for severe hearing loss is higher than what we observed from previous study, but the guideline has been adjusted, and closely every week patients benefit from audiogram. While we are moving towards the under operational research, we will be doing the trial of the shorter oral regimen for our drug-resistant TB patients. It has been planned for the program. Thank you.
Okay, thank you, Christelle. So the next question is for Alexander Lim. Did you try to trace patients in between diagnosis and initiation of treatment in order to identify the very early loss to follow up? Alexander?
Hi. Good evening from Manila. The patients that we traced were those who were lost to follow up during 2013 to 2016 treatment at the Philippine National TB Program for programmatic management of drug-resistant TB. There was an instance in the study wherein 2 of the patients that we were tracing were diagnosed with MDR-TB, died before taking the treatment, while most of the patients really just stopped taking their medicines while undergoing the treatment. Thank you.
Okay, thank you very much. So now we will move to Dr. John Otuba. I think if I understand well the question, I think it's for you. So how would you define delay in diagnosis of TB, and how was defined severe disease in the context of TB, and how it influenced the poor outcome? Thank you.
Thank you, Marilyn, and thanks for the questions. Our definition of severe TB disease was based on chest X-ray findings. These were patients who had bilateral chest field involvement or had more than 3 cavities in the lungs. And then also the patients that had extrapulmonary forms of TB, or rather disseminated forms of TB. Those were referred to as patients that had severe disease. Delay in diagnosis was defined as patients that were symptomatic for TB, but had taken 2 months and more to seek for care at the health facilities at a point when they were diagnosed with MDR-TB. So it was basically looking at that duration from the point when they had a diagnosis of MDR-TB, if they were symptomatic for TB 2 or more months longer. Thank you very much.
Thank you very much. Then a question to Wasilia Jassat, South Africa. So how do you think that we balance the push for decentralization to improve access to services versus maintaining the quality of services in a specialized facility? How can policy consensus between different stakeholders be reached for this scenario? Thank you.
Thank you very much, and a really good question, and that really is the focus of my PhD research. I think that it's always important to improve coverage, especially in settings where we know there's unequal distribution of services and care. And while that is the big concern, it's not the only concern. And I think that, it's not one or the other. We have seen settings where they were able to do slow, measured implementation to lower levels of care, but maintaining quality of care. And I think that some of the ways that they've done that and some of the good practices we've observed are facilitators of change, and so coordinators at a sub-district or district level who support linkage of patients, audit of care, training on protocols. So there are measures that could be put in place at a district or sub-district level to ensure that this is coordinated and that quality of care and clinical governance is maintained. But where districts rushed to decentralize services to lower levels of care without paying attention to this, I think we saw very poor outcomes, and we saw, loss of trust of the program with users and with the healthcare stakeholders themselves. Thank you.
Thank you for your answer. There is a question, I think it's probably for Alexander Lim. So the question is, what are the treatment support strategies in the program? I guess it's in relation to the adherence and loss to follow-up. Thank you.
I think for the treatment support, for the Philippines, we usually have these patient groups wherein patients could talk to each other and talk about their experiences during their treatments. And during those small group discussions with the patient groups, we learn as a program on their experiences during their treatment. Thank you.
Thank you for your answer. So we are done with the question from the audience. I will ask one question, and this is to Kenneth Mutesazira. So it was really interesting to see the effectiveness on the contact tracing. Quite interesting also to see that majority of the contact with TB were in fact drug-susceptible TB cases, which means that they probably get infected or not at the household level, but in the community. So do you have some figures for children to see if this was the same situation?
Thank you, Marilyn, for that question. Unfortunately, due to the challenges we all know around TB diagnosis in children, we are still peaking very low. So among TB patients, we have about 3% are children, but we think probably there are many more that we could be missing because of capacity gaps and also challenges around sample collection from children.
Thank you very much. And did you investigate a bit where people get infected? I don't know if you were able to do some individual story tracing to see a bit.
Well, this is the beginning of the work that we are getting to dig deep into it. It is one of the things that we want to do in addition to trying to link the infections through more studies. But we have not yet done that level of, it's one of the recommendations we have made to be able to study the transmission dynamics.
Okay, thank you. So since we are getting close to the end of the session, I think I will over to my co-chair if she has any questions, and then she will be able to conclude. Margaret.
Thank you, Marilyn. You're too kind. First of all, I would like to congratulate. I have been happy to see we have common problems. I come from Brazil, where we are conducting and trying to improve the results and outcomes of our control of TB. We are now searching to move to a shorter regimen as well. We are not using, for you to be aware, the Bangladesh regimen once we have detected a high rate of resistance for injectables as well as for quinolones in our country, because quinolones are free of charge provided by the National Health. And so what we are trying to demonstrate is another short course regimen using bedaquiline and pretomanid. As Marilyn mentioned at the beginning, I am conducting the clinical trial for Global TB Alliance, demonstrating whether it could be adopted or not. So we are just, and with other countries, finished the enrollment. Maybe some of you have participated in this trial as well. I guess Philippines is a member, and South Africa as well. And so what we aim is really demonstrate and to have accessible shorter regimens for our patients. So with this general comment and sharing the enticing comments raised by Martina Reichmuth with sequencing, I would open whether you have any personal comments on this general comment I have just made, and congratulate Marilyn for the conducting of this session again, and all of you hoping to see personally in a further moment. Thanks for all. Bye-bye.
Thank you.